How's it going, guys? So this is a challenging question for both step 1 and step 2. It's a bit factoidy. We could discuss this for 45 minutes, but I'm not going to waste our fucking time, okay? We're not going to discuss superfluous horseshit that has no relevance to your score. So before we get started, please subscribe to my channel. I really appreciate it. Give the video a like, really appreciate it. Find me on Instagram at Mehlman_medical, MEHLMAN_medical. The link is down below. Find me on Telegram. Recently created a Telegram group and channel. Links are down below. Now let's start the fucking questions. So 55-year-old dude, he has rheumatoid arthritis and diabetes, and he's on a bunch of meds: lisinopril, metformin, glibenclamide, simvastatin, aspirin. He drinks 4 beers every evening. Vitals are within normal limits, and he's got an abdominal bruit, and his serum studies are shown. So you will have the normal lab values available to you on the exam, but you have to take your fucking training wheels off, okay? You're going to be a doctor. Learn your fucking lab values. Stop your crying. So his sodium is normal at 140. The range is 135 to 145. Potassium, normal at 3.8. The range is 3.5 to 5. Chloride should be 95 to 105. His is quote-unquote elevated at 108. I say quote-unquote elevated because if your chloride is out of the normal range, it doesn't mean anything for USMLE almost always, okay? It's just we make note that 95 to 105 is what we'd expect. But it doesn't matter if your chloride is low or high on USMLE. So bicarb is low at 20 milliequivalents per liter, normal range 22 to 28. Glucose is impaired fasting. He's got diabetes. We don't expect his glucose to be normal, okay? But 72 to 99 is what we expect for fasting. 100 to 125 is impaired fasting glucose. 126 or greater on 2 separate occasions for fasting is diabetes mellitus. He's already diagnosed with diabetes. So the question's asking the most likely explanation of these findings. And you say, well, what am I fucking looking at? Like, what do you mean? What findings? Well, he's got low bicarb. Okay, that's what he's got here, which would be a metabolic acidosis. So we say, well, what could cause his metabolic acidosis? I mean, he's on various medications. Lisinopril, an ACE inhibitor, can cause hyperkalemia, can cause a dry cough. Doesn't classically cause metabolic acidosis. In theory, if you're inhibiting RAS, you could retain protons distally. Not classically associated with metabolic acidosis. Metformin causes lactic acidosis. I mean, this is a known thing, okay? So this would decrease your bicarb. We're not jumping to conclusions yet. We're just making contemplations. So metformin can cause lactic acidosis. Glibenclamide, I'd say 99% of students seeing this clip have no fucking idea what that is. This is similar to glyburide. It's a sulfonylurea, which is an insulin secretagogue. Glibenclamide is classically known in the literature for causing hypoglycemia. Very fucking rarely used, okay? But when we consider the notion of sulfonylureas inducing hypoglycemia, glibenclamide is the quote-unquote famous one for doing that. Statins, I mean, obviously hepatotoxicity, myositis. Aspirin can cause a mixed respiratory alkalosis, metabolic acidosis, as well as tinnitus. So we just go through our answers here. Choice A, alcohol use, wrong fucking answer. There's no reason to assume it. Alcohol could cause lactic acidosis. And we say, is this lactic acidosis, right? I mean, it's a separate answer choice here. And so as I prefaced with, I was going to cut to the chase. So why don't I just fucking do that, all right? We need to calculate anion gap. So anion gap on USMLE is going to be, you add the chloride and the bicarb, okay? You take that number, in this case, 128, and then you subtract it from the sodium. And in this case, that would be 12. Now, normal anion gap is 8 to 12. If you are 13 or greater, you're elevated anion gap. Mud piles are diagnoses for elevated anion gap metabolic acidosis. Methanol toxicity, uremia, which is renal failure, DKA, fenformin, some weird drug you don't need to know. I is iron tablets / isoniazid, L lactic acidosis, E ethylene glycol, which is antifreeze, S salicylates, which is aspirin. So those are all high anion gap metabolic acidoses, 13 or greater. This is 12. So let's look at our answer choices here again. Lactic acidosis, salicylate toxicity, wrong fucking answers because they're mud piles, okay? Glibenclamide, we don't have hypoglycemia here, okay? It's just a distractor. When students don't know an answer, they choose weird sounding shit. Never heard of glibenclamide before in my entire life. Maybe that's right. It's the wrong fucking answer. Crohn's disease, completely outrageous answer. But if this were a Qbank and we were to see stats, you'd probably get like 4% of people just randomly choosing that for whatever reason. There's nothing about diarrhea here. Zero reason to suspect IBD. It's just in there as a miscellaneous distractor. Now, renal tubular acidosis. This is not one of the mud piles, okay? And this is classically a normal anion gap metabolic acidosis. Now, this is sort of what you need to know for USMLE. Students will fixate about OMG, RTA type 1, 2, 4, the mechanisms, and like, the urine findings for pH and all of this fucking horseshit. It's not my opinion. It's a matter of what have I observed across thousands of questions on step 1 and step 2 level NBME exams. And it's been to my observation that the way USMLE assesses renal tubular acidosis, RTA, is they give you a vignette like this where it's fairly vague. You're not really sure what's going on. And then when you have to try to eliminate, you're going to calculate the anion gap and it will be normal. Okay, 12 is considered normal. So you eliminate the answers. It's a diagnosis of exclusion on USMLE. We've eliminated lactic acidosis and salicylates. Okay, salicylates, aspirin. We've eliminated those because they're mud piles. We've eliminated glibenclamide. Alcohol, if anything, would cause lactic acidosis. These are the same answer and the wrong fucking answer. Crohn's disease, outrageous. And we're left with RTA. It's a diagnosis of exclusion. Okay, I mean, we could articulate the possibility of like causes of RTA. I mean, could it be diabetes? Could it be things like multiple myeloma, Sjögren's syndrome, Fanconi syndrome? Okay, so there's different causes, but what USMLE cares about, how they actually assess it without wasting our fucking time, is just you're going to get a relatively vague vignette and you're going to calculate the anion gap as normal. Okay, and you're left with RTA. Once again, in recapitulation, you're going to take chloride plus bicarb, add them together. You take that number and you subtract it from sodium. 8 to 12 is normal. If it's 13 or greater, that's elevated, and that's going to be one of the mud piles. You know the deal. I'm going to continue to make more content. If you like my stuff, subscribe my channel. And I appreciate your time. That's it.